Thank you, Darais, for that kind introduction. And I won't take much time. Anirudh, you had a wonderful talk, and you can always give your comment at the end of my talk because you are a stalwart even in the OCTA in uveitis, and I have always benefited from your talks. So, you see, there is the importance of vasculature in any patient of uveitis. You see here that there is an area of activity over here, and here the external limiting membrane is disrupted and the ellipsoid zone is disrupted, but here there is a complete loss. So here the circulation is still there. That means this area is still salvageable. While once you've lost the circulation, that means there is not much to salvage. So that's the importance of the circulation in a patient of uveitis. Classically, when we are looking at uveitis and OCTA, we want to see the white dot syndrome, which is a constellation of various inflammatory disorders affecting the outer retinal layers and choroid. And we'll talk about a few of them and their protein manifestations. When I was a fellow, we had to learn the pattern recognition of fluorescein and ICG leaks to try and label these entities. And we didn't really understand the exact pathology that was causing the disease entity. Now with OCTA, we are able to understand more and more. So PIC is one entity which shows a very small punctate lesions in the retina. They may be pigmented if they are healed, and sometimes if they are active, they'll be in this creamy color. But what is important is that there is not much to be seen here in terms of the changes in the circulation in the choriocapillaris layer, but about 40 to 70% of these patients have got a choroidal neovascular membrane. Now, in this patient, a subtenon tricot has been given, which has decreased the inflammatory component, but you can see here that the component of blood flow is still present. So what has happened after the injection is that the CNVM is still persisting because it's an injection of steroid while the inflammation has gone down. So the importance of multimodal imaging, especially OCTA in PIC, is to look for the CNVM. Now, when we come to MUDES, it's another interesting entity where the OCTA has helped us to understand that there is no changes in the retinal microcirculation and at the level of the choriocapillaris and the choroid. But then what is it that is causing those spots and dots? So you see in MUDES the white multiple lesions which cause the larger spots and the finer dots. These are present closer to the fovea while these are dispersed over the posterior pole. So here is one patient of mine. You can see these white dots here, and you can see that there is a disruption of the ellipsoid zone that is present here, but the ICG is showing multiple hyposinuscent areas all over the fundus at the posterior pole, nasally and inferiorly. Now, this is confirmed that with the EOG and the pattern ERG, as well as the multifocal ERG showing that there is a decrease in the perifoveal response. But when you do the OCTA, you find that at the level of the choriocapillaris, as well as in the deeper choroid, there is no change. So um, in MUDES, there is no microcirculatory change. And this has led to the concept of understanding that the inflammation is at the level of the photoreceptor, and it has led to what we call photoreceptoritis, and there is a disruption of the loss of the inner and the outer segments, and once it regenerates, you get the retinal function back again. And what you are seeing, the hyposinuscence in the ICG, is actually a masking effect because the outer retinal changes and there is no actual response involvement of the capillaries or the choroid. Now, when we come to serpiginous like choroiditis or serpiginous choroiditis, which is very common in the Indian subcontinent, you see here a large lesion that is infecting the posterior pole, and you can see the autofluorescence that is helping you to see the active edge. When you do the spectral domain OCT, you can see a localized area of inflammation that is very classically seen here. And then the OCT angiography is showing you the areas of non-perfusion or capillary voids that are present there. And as the inflammation comes down, the thickness comes down, and you see that the voids are going away. So in serpiginous like choroiditis, one very important thing is that you can monitor the response of treatment by the looking at the capillary voids. Probably it is not helpful in diagnosis as much as it is in the management of these cases. And this is here a case where there is a large serpiginous patch over here, and there is a CNVM that has developed at the edge. I will like to share one very interesting case that I have been following up for 1 decade now. So this patient presented in 2011. This was the lesion here. And at that time, we did not have an OCT A. So you saw this lesion in 2011, and till 2014, this lesion remained stable. In 2015, they started to increase, and obviously, one would think that this is a reactivation of the serpiginous like choroiditis patch that is present there. And in 2015, towards the end, a small hemorrhage came here, which could then be imaged by the then modalities of autofluorescence and fluorescein angiography. So we missed a very early choroidal neovascular membrane till the hemorrhage came. So that is the importance. And now we gave the loading doses of anti-VEGF, and that worked. And now we monitor this patient with an OCTA, and we can do a SSOCT and see that the CNVM is stable. So there has been a paradigmal shift from fluorescein angiography and autofluorescence to looking for these subtle choroidal neovascular membranes in these patients of choroiditis. And Anirudh has been working extensively, and his group at PGI earlier, where he was, have actually staged the tubercular multifocal serpiginous choroiditis into 4 based on the fluorescein angiography of autofluorescence and also on the OCTA findings. Then looking at MP, that's again one place where you can see the voids in the at the level of the choriocapillaris. And what is interesting is that these voids of ischemia are beyond the areas of the clinical lesions. So as Anirudh had said, you must look at the red-free photograph, you must look at the en-face image, and then you correlate whether these are masking lesions or these are lesions which are true voids that are present. So here you can see that the void is larger than the retinal lesion, implying that there is a true capillaritis at the level of the choriocapillaris in MP. This is VKH. We now know that there is fluid here and large voids are present, and these are true voids, and they can be monitored serially, and they correlate more with the ICG angiography, and after treatment there is a complete resolution. So when there is a diagnostic dilemma between whether it's a CSR or it's a VKH, what's important to realize is, then this is again another one of the papers from Dr. Anirudh, who's here, and that the masking that you have in CSR correlates with the fluid, while that in the case of VKH, you have true voids which are larger than those that you can see clinically or on the en-face image. So that helps you to differentiate a VKH from a CSR. Then the ultra-wide field angiography is now being done as an OCTA as well, and you can see that in retinal vasculitis. You can do a montage imaging, and you can have a really good picture of what is happening in retinal vasculitis as well. So now, from what I showed you, the fluorescein angiography, where you're looking at early hyperfluorescence with late hyperfluorescence, and you're trying to look at block fluorescence and trying to see whether it's a pigment or a hemorrhage. We are now going towards pattern recognition of OCTA images in uveitis. You can see that in retinal vasculitis and in birdshot choroidal retinopathy, it is the superficial and the deep capillary plexus that is involved. In nudes, there is a normal flow without any involvement of the inner or outer circulation, and that helps you to exclude other choriocapillaritis. MP has got a flow reduction and ischemia in the choriocapillaris and the choroid. And in PIC, you can see the CNVM that is important, which is the most important component. In serpiginous choroidopathy, you have flow reduction in the active lesions, which decreases and resolves as the inflammation is coming under control. And in VKH, you can have focal flow voids which respond very well to treatment. So now the pattern recognition in OCTA is helping us in making a definitive diagnosis. Thank you very much for your kind attention.